Hello again. Here we are at chapter 32. This is functional assessment of the older adult. We're going to differentiate activities of daily living and independent activities of daily living. We're going to look at goals for performing functional assessment, discuss the three domains of a functional assessment. So let's get right into it. Okay, so when we're assessing the older adult, we want to be sure that we do a comprehensive assessment. We need to have information related to how does aging affect the older adult. We want to look at patients' lifestyle, maybe chronic diseases, and then we want to look at the patient's mental status. We look at their functional status. We want to see if the patient's having any pain, and maybe look at their physical environment if we can, to see if there are any concerns, any safety risks that's causing the patient to have maybe functional issues. So you're going to assess, do a physical exam, not only of the patient, but you also want to do an examination of the environment as well. Now we know that in the United States, we have a large population of older patients. And so again, in the United States, we have an older population. Large amount of our population is older than 65 years old. And anyone 65-year or older is considered an aging or older adult. And then they sort of break that down into the old, which would be 85 years or older. And then, middle old would be 75 to 84. So it breaks down into the different age categories, but we know that we have a large population of older adults in our society. And a large amount of that, about 80% of home care visits and 90% of the older adults are actually in nursing homes and we care for. Now, a large amount of older patients are also now staying at home. Either they're staying in their own home or they're moved in with, say, an adult child. So home care services being provided to a large population of older adults as well. Now, normal changes when a person ages, not necessarily because of there's a problem or a pathology, there's a disease process going on. It's just the normal changes that occur as the person is getting older. You recall all the chapters we've been through that discuss, developmental changes in the older adult, right? We know the eyes change, we have some changes in the ears, as in hearing, we have changes in the skin integrity, we have changes in the heart, the blood vessels. So there are changes that occur just as the person is getting older. It doesn't necessarily mean they have a disease process. But these changes can actually predispose the older person to, potential problems. And so we assess our patients for these because some of these problems will now cause the patient not to remain in their home because they wouldn't be safe. And so they may have to move on to, say, a nursing home, or a skilled nursing care facility, maybe being a rehab for a short period of time, etc. So we have to do a functional assessment in order to see if that patient is safe and at home. Okay. So some of those issues could be a patient that have maybe pneumonia, they're confused, they fell, sleep disorders, okay? So these are some of the issues that actually put our patient at risk. So we assess the person's ability to be able to perform activities that will help them to remain safe at home. So there are activities such as maybe being able to use the telephone if there's an emergency to call 911, being able to drive, being able to give themselves a bath, like ADL activities. And then activities that has to do with functional status, such as maybe are they having potential problems with being motivated to do something. Okay. Maybe it's because their vision is not appropriate. Maybe it's because their hearing is not appropriate and they need additional assistance for that. And then how much assistance is required. So a nurse or a physical therapist or occupational therapist may be actually in the home or where the patient is in order to see what the needs are, what kind of requirements these patients require. So when we do a functional assessment, we want to provide a few things. First, it gives us a baseline as to where the patient is so that we know if in the future the patient has had a decline, at least we would have baseline information on the patient. Or it can tell us how much service we need to provide for the patient. So if the patient is not doing well at this point, we can actually make a prognosis that the patient is only going to get worse and they're going to require additional care. Or we can say, okay, well, this is where they are. They're actually progressing. And so the patient may not need rehab services in another 2 weeks or 3 weeks. We can also identify a patient's strengths or maybe even their limitations. Their strength would be that they are able to actually do some ADLs. That maybe the limitations would be that they don't have the person to go to the store and to buy the food shopping. So the IADLs would be a limitation for them. So we can identify areas where we can plan for future needs for these patients. So we look at the 3 areas that we look at, the 3 domains are activities of daily living, instrumental activities of daily living, IADLs, and also the patient's mobility. So I've given you a little puzzle here for you to fill in. So what are the activities of daily living? So there are blank sheets, and try to see if you can actually put the appropriate letters in to make words. These are all under activities of daily living. Have fun. Okay, so there are different types of instruments or some assessment tools that are utilized to assess a person functional status. We can actually use the CATS Index of Independence in ADLs to actually take a look at the person. And it's based generally on their physical disability, and it measures physical function in the older person. Okay, it's used with basic ADLs. We're seeing if the person can actually perform those ADLs. Now, it takes like 5 minutes, and it's easily used in a lot of situations. Now, when you use these scales, the patient will have to demonstrate. Like if I'm looking at their ADLs and I'm wondering, can the patient actually get up and go from their bed to the toilet? You actually have to see them do that. They can't just tell you that, yes, I can, because sometimes our patients tell us that they can when indeed they actually can't. Or it would be helpful if they have some kind of adaptive equipment to help them, like maybe a raised toilet seat or maybe a walker to help them. And then some other assessment tools that are required, that are utilized, would be functional independent measure tools that we use, rapid disability rating scale that's also utilized, or the Barthel index that's utilized. And you guys can actually look up these information in your book to actually look at some of the information, like Lawson's Instrumental Activities of Daily Living. Lawton's is utilized as well. And for those people that are sort of living at home, maybe in an independent living, these scales are self-reported, and so these are tools that can be utilized with the patient. So again, the goal is to measure, when we do instrumental activities of daily living, to measure the functional assessment of our patient. So some IADLs that they could be utilizing, or that they could be doing, maybe requiring some assistance with, is meal preparation. Now we've heard of Meals on Wheels, like, right? Or a home health aide that will come in and help them with making a meal, or providing some housekeeping services, maybe doing their laundry for an hour. And then maybe the patient requires the nurse to help them take their medication. Okay? Maybe all they need is transportation services to get to the doctor's office. So whatever is required, those are IADL activities. Okay, and Sometimes we just look historically at what women do and not necessarily the tasks that men do as well. Because what if this is an older person who lives at home and it's a guy and they're used to doing, you know, the male tasks, such as maybe mowing the lawn. We have to look at, is this individual going to be able to safely mow the lawn, or does he require additional assistance in order to do this? Okay, so we look at those areas as well. So some other tools, Lawton's Instrumental Activity of Daily Living, I sort of just mentioned a few minutes ago, and that is actually on page 827 that you can see some questions related to it on 827 there. And also we use the multidimensional functional assessment questionnaire IADLs as well. We have the get up and go test that we can use to measure physical performance on that patient. And what that is, it gives us a reliable information on the person's functional mobility status. It's quick, it's easy, we don't need anything in order to do it. All we have to do is observe the patient getting up from a chair, walking about 10 feet, turning around and walking back and sitting down on the chair. Now what you're looking for is you're looking to see if the patient uses additional things. So I don't know if you've ever seen like an older patient, they get up and they use the walls or the chair or the furniture in order to help them move around. Excuse me. Well, sometimes that would not be safe for the patient. So they need to be able to get up independently by themselves, walk a few feet, turn around, and then sit back down. So you're looking at what their balance look like. Did they have to use the, you know, the walls to get there, etc.? Because in an emergency, if they're in the home and need to get out quickly, are they going to be able to do this? Okay, so anyone who takes longer than about 12 seconds or so is at high risk for falling, and so they may need additional support in order to help them. We also assess a patient's cognitive function. We look at their attention, their memory, orientation, language. We look at all of that information. And I think the last lecture, a few chapters ago, talked about that as well. So we look at their cognitive status. Mental health status is also very important, okay, in doing functional assessment. Patient that has dementia or delirium or that are depressed could be at risk for falls or to hurt themselves as well, and may not be safe at home. So it looks, especially if this is done inpatient, it can give us a sense as to what kind of you know, home care services we refer for our patients. Now, I did mention in the abuse PowerPoint about caregiver stress that can occur. So here again, we have caregiver stress that could occur with our patient. You know, patients that are older themselves are caring for older patients. Now that could be a potential problem. Patient having an older person that is debilitated and require care for a long period of time, that can also cause burnout in these, you know, caregiver, whether young or old, and that could potentially then put the patient at risk for abuse, right? It can affect the person's sleep, you know, increase mortality. Now, what is quite strange is that sometimes you find the caregivers, because now they're caring for someone else, they don't care for themselves, the caregivers end up dying before the person that was already sick. That is sort of strange, but we can certainly understand it, simply because the stress and the strain is so much, and then you know, they're ignoring a problem that may be occurring with them in order to care for the older adult, put them at risk for poor mortality. Elder mistreatment, I'm not going to spend a whole lot of time because we sort of went over this already. So we just have to keep evaluating for it to know that it is, you know, elder abuse is out there, and we are mandated reporters. So we want to document everything that our patient tells us. You know, I'm struggling to get to the kitchen, or I can't get to the bathroom, or, you know, I've fallen last week. We need to document all of that information, record it appropriately so that we can get the patient potential assistance as is required. And then, of course, if there's any information related to abuse, that you're going to document those as the patient says, so verbatim information. So what are some things that we can change in the patient's environment so that their risk can be reduced? Well, if we look at something like, if you've ever seen like maybe an older person, like a grandparent or something, and you go to their home and you find that they have all these throw rugs on the floor because they're beautiful. Yes, they indeed are beautiful, but it puts these patients at risk for falls. And so you want to be sure that you don't have a whole lot of throw rugs around the homes of an older person, because their gait will potentially not be very steady anymore. They may be using, say, a walker or etc., a cane, and it could cause them to trip and fall. There may not be enough lighting in the person's home in order for them to see, so we got to be sure that we provide lighting. The toilet seats may be too low for the person. If they've had a hip replacement, they maybe cannot get up once they sit down so low, so we may have to have a raised toilet seat to help. And do they have access to transportation to help them? So these are some of the things that we look at. We also sometimes don't pay too much attention to the spiritual needs of our patients, and we need to. We have patients that when they're in the hospital sometimes ask if a chaplain could see them, or the elder from the church or their pastor, etc. We need to take these into account because that will allow the patient to improve and feel much better. So we need to assess the patient's spirituality as well. So open-ended questions we can ask the patient. Now, granted, just be aware that sometimes our care or timing for our care may have to be put off simply because our patient need to have that, maybe that person is visiting someone from their church and they're having prior meeting with the person. It would be very rude to interrupt at the time. So you have to work your care around what is going on with the person as well. Sleep is also very important for the older patient. That's how our body regenerates itself. So we have to be sure that our patients are getting enough sleep. Mental health disorders occur because sometimes our patients have insomnia. They're taking medications that have side effects that will cause the patient to be awake or cause maybe the patient to not go to sleep or to sleep at off hours, etc. They have to get up, like a patient is on maybe a diuretic that causes them to use the bathroom, to urinate frequently, and that gets them up like every hour of the night. Their sleep is interrupted, and now in the daytime, of course, they're very tired because they got no sleep. So we have to be aware of some of those medications as well. And some meds put our patient at risk for falls, right? Blood pressure medication a patient could be taking could cause hypotension. And then they stand up, they all of a sudden feel lightheaded, they fall and maybe fracture a hip, etc. So we have to be aware of that as well. Obesity can be a problem, and patient can have poor health related to obesity. Okay. Again, if they're mentally impaired, okay, they can potentially pose a risk to our patients. So what are some things you think we can do to help with non-pharmacological sleep interventions? So what can we do with our patient instead of telling them to take additional medications to help them sleep? How about maybe a warm bath would be helpful? If they can take a warm bath, maybe having someone do maybe a massage, maybe listening to music. Okay, you guys get my drift. You can think about some of those things as well. So culturally, we have to look at what affects a patient as well. Sometimes the interventions that we provide our patient are not culturally appropriate. So you have to be sure that you're looking and giving the patient, culturally appropriate information. Because if you provide something that they're not going to be utilized or they don't do in that culture, then of course they're not going to do it to make them safe, right? Some people think that it makes them seem old if they have to walk with a walker. well, maybe for that person, instead of using a walker and make him feel so terrible, maybe we can use a cane, but not the single leg cane. Maybe it would be one of those 4-prong canes, right? The one that have a wider base. Maybe that'll be helpful for that patient. So we have to look at what the patient's needs are, what culture, how culture affects that person's life, and then complete our assessment or intervention for that patient. Nutrition is a major one that comes into play here. If we're going to provide a patient, say, from a culture that does not really want the American diet, yet we go and we refer Meals on Wheels to the patient, and we have the meals delivered 3 times a day, 7 days a week. Well, if your patient don't eat that type of food, do you think they're going to eat it? I have seen plenty of home care patients who got Meals on Wheels and did not touch the food. Why? Because it's not food that they're not used to. They're not eating that because it's not part of their culture, so they're not willing to eat it. So we have to be wise in those assessments and interventions that we provide for our patient. Okay. Pain is also a major problem with our patients as well, and with pain we have to be sure that we assess, because it'll prevent our patient from getting some things done. Again, culture comes into play regarding pain, so we have to be sure that we assess pain appropriately, manage pain appropriately, because we know acute pain, if it's not managed appropriately, will become chronic pain. And sometimes our older patients don't want to bother us, right? And they don't want to become addicted to medication, so they end up not taking anything, and therefore they'll end up suffering and can cause some, range of motion, limitations in range of motion or limitations in activity because they're experiencing such pain and discomfort. So things like maybe arthritis cause a lot of pain, osteoporosis, patients that have cancer have pain, and some other disorders such as maybe shingles is very painful for a patient. So they can experience some things that cause a lot of discomfort as well. We have to be sure to manage it appropriately. So a variety of things that we utilize, and it's not necessarily just medication as well. Think about some complementary, alternative methods for managing pain. So remember, pain is what the patient says it is. It's not what we think, it's what the patient says. So we want to look at altered cognition for our patient. Again, we're going to try and get as much information as possible. Now, maybe your patient may not be the most reliable because their cognitive function is altered. So maybe it's a family member that we're going to ask, or maybe we have to call their primary office to figure out what's going on with the patient. And directly speak with your patient. You don't ever want to speak in third person related to your patient or speak around them. Remember that, sometimes even if they're having a problem, they can still respond to some questions. So just be aware of that. Not because they're getting older and they have maybe dementia or some delirium means that we're going to be treating that person as a child. So we have to be respectful still and be aware of how we're getting the information. Okay. Any questions? Thank you very much for listening.